Hello and welcome to Insight Ophthalmology. I am Dr. Amrit and I welcome you to another lecture on retinal detachment. Before we focus on tractional retinal detachment, let us first place it within the broader framework of retinal detachment. A RD or a retinal detachment means that the neurosensory retina has separated from the underlying retinal pigment epithelium or the RPE. As discussed in previous videos, there are three principal mechanisms. The first one is rhegmatogenous retinal detachment. Here, a full thickness retinal break develops and that allows liquefied vitreous to enter the subretinal space, followed by the development of retinal detachment. This mechanism was covered in detail in our previous videos on rhegmatogenous retinal detachment and its treatment. So here, we will use it here only for comparison. The second mechanism, which is the focus of this video, is the tractional retinal detachment. In this case, the retina is not primarily lifted by fluid passing through a retinal break. Instead, a proliferative or a fibrotic tissue attached to the retina contracts and mechanically pulls the neurosensory retina away from the retinal pigment epithelium. So the simplest sequence to remember is that there is traction followed by retinal elevation. A causative retinal break is not required in a pure tractional retinal detachment. The third mechanism is exudative or serous retinal detachment. Here, the fluid accumulates beneath the neurosensory retina without a primary retinal break and without traction being the main cause. So what is the problem? The underlying problem here may be inflammation, abnormal vascular or choroidal leakage, impaired fluid handling by the RPE, choroidal congestion, a tumor, or another process which is disturbing the normal subretinal fluid balance. Don't worry, we will discuss exudative retinal detachment separately in the next lecture. For the present lecture, it is enough to remember this basic distinction between the types of RD. In rhegmatogenous retinal detachment, the central problem is a break. In tractional retinal detachment, the central problem is mechanical pulling. In exudative retinal detachment, the central problem is abnormal fluid accumulation caused by another disease process. Remember, these are not rigid categories because more than one mechanism can occur in the same eye. For example, a tractional retinal detachment may later develop a full thickness retinal break, and once that happens, the eye no longer has a purely tractional detachment. It has now developed combined tractional rhegmatogenous retinal detachment. Understood? Okay, now let's properly define what is a tractional retinal detachment. The central definition to remember is that a pure tractional retinal detachment is the mechanical separation of the neurosensory retina from the RPE by pathological vitreoretinal traction without a causative full thickness retinal break. But traction here does not always produce a retinal detachment. Remember that. So in tractional retinal detachment, traction is important, but a traction itself will not always produce a retinal detachment. A contracting tissue may initially produce retinal wrinkling, it can produce vascular distortion, retinal folds, or it can also cause displacement of the macula without separating the full thickness of neurosensory retina from the RPE. It may also lead to production of something known as tractional retinoschisis, where the traction will actually cause splitting within the layers of retina and not really the split between the neurosensory retina and the RPE. A true tractional retinal detachment is said to be present only when the neurosensory retina has actually separated from the RPE and a subretinal space has formed. This distinction becomes particularly important on OCT because an elevated or a distorted retina in proliferative diabetic retinopathy does not automatically mean that a true subretinal detachment is present. Okay, so before labeling an abnormal retinal elevation, what you see on OCT as a tractional retinal detachment, you need to ask three questions. Number one, is this surface distortion? Is this intraretinal splitting? Or has the full neurosensory retina genuinely separated from the RPE? Now let us understand how this pathological traction develops. We will try to understand it first with the commonest cause, that is proliferative diabetic retinopathy. We know that the proliferative diabetic retinopathy begins with retinal ischemia. When large areas of retina become inadequately perfused, the ischemic retina produces signals that promote neovascularization. But these new vessels do not grow alone. They grow together with connective and fibrous tissue, forming what is known as fibrovascular proliferation at the vitreoretinal interface. An important structure in this process is the posterior cortical vitreous, also called the posterior hyaloid. The posterior hyaloid basically provides a scaffold along which the neovascular and the fibrovascular tissues can grow. Their pattern of proliferation therefore depends partly on where the posterior vitreous has already separated and where it remains attached to the retina. As the proliferative tissue matures, its vascular component may become less prominent while the fibrous component contracts. Because this tissue remains attached to the retina, its contraction can now transmit the force directly to the retinal surface. This traction can actually act in two main directions: anterior-posterior traction or the tangential traction. The first is the anterior-posterior traction. Here, the posterior vitreous remains attached to the areas of the fibrovascular proliferation, while other portions of the vitreous will pull anteriorly or separate. This lifts the retina at the points where the vitreous remains firmly attached. The second is the tangential traction. Here, the fibrovascular membrane contracts along the surface of the retina, and this can produce retinal wrinkling, folds, or displacement of the macula and distortion or dragging of the retinal surface. Okay, so the pull can occur in two ways, either anterior-posteriorly or tangentially. In practice, however, the anterior-posterior and tangential traction frequently coexist. As these forces increase, they may distort the retina without detaching it, or they may eventually become strong enough to separate the neurosensory retina from the RPE, and that is when a tractional retinal detachment develops. So the main sequence to remember here is that retinal ischemia leads to neovascular and fibrovascular proliferation. This tissue grows along the vitreoretinal interface, undergoes fibrosis and contraction, and then produces anteroposterior and tangential traction that distorts and may eventually detach the retina. Not just PDR, but any disorder that produces sufficiently strong proliferative or fibrotic tissue at the vitreoretinal interface can create a tractional component. Let's discuss the causes. The causes are easiest to understand according to the process that produces that tractional tissue. The first and the most important group is the ischemic proliferative retinopathies. Here we have PDR as discussed, proliferative sickle cell retinopathy, Eales disease. PDR is by far the most important adult cause. And the same broad pathway can also occur in proliferative sickle cell retinopathy. Here, peripheral vaso-occlusion occurs, which produces retinal ischemia, neovascularization, and subsequently fibrovascular traction. Advanced diseases in proliferative sickle cell retinopathy may also produce vitreous hemorrhage, TRD, or a combined tractional rhegmatogenous detachment. Another example is the Eales disease. Here, peripheral retinal periphlebitis and non-perfusion may lead to neovascularization. With recurrent hemorrhage and fibrovascular proliferation, advanced Eales disease can develop significant retinal traction and TRD. Similarly, severe ischemic retinal vein occlusion that can also, on rare occasions, produce enough neovascular and fibrovascular proliferation to cause a tractional detachment. However, this is much less common. So these were the causes in adults. In children, the major proliferative causes are the ROP, that is retinopathy of prematurity, familial exudative vitreoretinopathy or the FEVR, persistent fetal vasculature. In retinopathy of prematurity, incomplete retinal vascular development leaves the peripheral retina avascular. Severe disease because of that avascular retina and ischemia can produce fibrovascular proliferation and progressive vitreoretinal traction. Stage 4 ROP describes partial retinal detachment, while Stage 5 describes a total retinal detachment. But it would be an oversimplification to say that every advanced ROP detachment is purely tractional. Advanced ROP may contain tractional, exudative, or mixed components. Another important developmental disorder is the familial exudative vitreoretinopathy or the FEVR. In FEVR, we see incomplete peripheral vascularization, which can lead to retinal ischemia, neovascularization, fibrovascular proliferation, and ultimately the retinal detachment. Despite the word exudative in its name, the familial exudative vitreoretinopathy does not produce only exudative detachment. The detachment here may be tractional, exudative, rhegmatogenous, or mixed. Then we have the persistent fetal vasculature. This is another pediatric cause in which persistent embryological fibrovascular tissue can exert traction on the retina. So this was the mechanism wherein the ischemia was responsible for fibrosis. A different mechanism of fibrosis actually occurs in proliferative vitreoretinopathy or the PVR. PVR should not be treated as identical to the fibrovascular proliferation that we saw in diabetic retinopathy and the above mentioned causes. In PVR, the contractile membranes develop as a part of the abnormal wound healing response, commonly after rhegmatogenous retinal detachment, retinal breaks, previous retinal surgery, or significant ocular trauma. These membranes may develop on the retinal surface, they may develop beneath the retina or within the vitreous, and their contraction can produce fixed retinal folds, shortening of the retina, and a substantial tractional component. Because a retinal break is usually already present in these cases, PVR commonly produces a complex or a combined or a mixed tractional rhegmatogenous detachment, you can call it anything, rather than producing a classical pure TRD that we saw in diabetic retinopathy. Similarly, severe ocular trauma can also cause traction through the same PVR related pathway. Another mechanism is selected inflammatory disorders, which may also develop secondary fibrosis or PVR and therefore acquire a tractional component, although these are much less common causes. So the disease processes are not identical. Diabetic retinopathy and other ischemic proliferative retinopathies produce neovascular and fibrovascular tissue. PVR produces contractile membranes through an abnormal reparative response. And developmental disorders such as ROP, FEVR, and persistent fetal vasculature have their own underlying anatomy. But all of them can reach the same final mechanical result, that is, a contracting tissue that remains attached to the retina and pulls it away from the RPE. Let us see how these tractional forces alter the shape of the retina. In a classical pure tractional retinal detachment, the retina is pulled at specific points where the posterior vitreous or the fibrovascular tissue remains firmly attached. Because of these fixed attachment points, the retina does not lift as a single smooth sheet like what we saw in rhegmatogenous retinal detachment. Instead, it forms a characteristic configuration. The most typical appearance is tenting or peaked elevation at the sites of strongest traction, with the retina between these points forming a concave or a scooped out contour. This gives the classical tractional pattern. You will see tethering at the focal points, tented or peaked elevations, and relatively a concave configuration between the attachments. Also, there will be reduced mobility compared with the rhegmatogenous detachment. A useful way to think about this is that the retina is being held down and pulled up at different points rather than simply floating on the subretinal fluid. Also, fibrovascular membranes may be visible as sheets or bands or plaques on the retinal surface. As they contract, they can wrinkle or pucker the retina, create fixed folds, or distort the normal retinal contour. The retinal vessels also reflect this tractional stress. They may appear straightened, they may appear dragged or displaced towards the point of traction. If the posterior pole is involved, the macula also can become distorted or displaced, leading to metamorphopsia even before true foveal detachment. So, in key morphological clues of TRD, we talked about fibrovascular proliferation, focal vitreoretinal attachment points or tethering, then we saw tenting or peak elevation, retinal folds and wrinkling, vascular dragging, and macular distortion. Now, here's an important nuance. A pure TRD is often concave and relatively less mobile, but these are not mandatory findings. Chronic rhegmatogenous detachment with fibrosis or PVR changes can also become stiff, and combined tractional rhegmatogenous detachment may also show mixed shapes. So instead of relying on a single shape descriptor, the key question is, do the visible attachment points that I see and the membranes that I see explain the pattern of the retinal elevation or configuration? So if you follow that question, you'll be able to diagnose better. Now, based on the relationship of TRD to the macula, a tractional retinal detachment can be described as extramacular, macula-threatening, or macula-involving. In extramacular TRD, as the name suggests, the detachment does not involve the fovea. A macula-threatening TRD is approaching or progressing towards the macula and places the central vision at risk. There is no universal numerical distance that defines whether a TRD becomes macula-threatening. The assessment here depends on the configuration, the direction of progression, and comparison with previous examinations or imaging. In a macula-involving TRD, the foveal neurosensory retina is detached from the RPE. Now, this classification should be based on the retinal anatomy and not on the visual acuity. A patient may retain good central vision even when traction is progressing towards the fovea. Conversely, reduced vision does not necessarily mean that the fovea is detached, because sometimes the reduced vision might be because of vitreous hemorrhage, macular ischemia, diabetic macular edema, or retinal distortion. All of those things also may reduce the vision. OCT is therefore particularly useful. It can show us whether the fovea is attached or detached. It can show us how close the tractional elevation lies to the macula, whether there is associated macular distortion, and whether the anatomy is progressing on the serial scans by comparing the serial OCTs. So when assessing the macular relationship in TRD, the key questions are that, is the fovea attached? And if it is attached, is the traction stable or progressing towards the fovea? This distinction will later play a major role in deciding between observation and surgery. Okay, in the beginning of this lecture, I told you what is the difference between TRD and combined TRD and rhegmatogenous retinal detachment. Now, the important clinical question to ask is that not simply whether traction is present, but whether traction alone still is explaining the entire detachment. So, you have to suspect that a rhegmatogenous component has developed when a previously localized tethered or relatively concave TRD now becomes extensive than the visible traction would explain. Also, now suppose the TRD, which was concave before, becomes convex or bullous and sometimes more mobile or extend towards the peripheral retina and the ora serrata. The most useful clue is a mismatch between the amount of visible traction and the extent of retinal detachment. A full thickness retinal break may be visible, but it may also be very small sometimes or hidden beneath a fibrovascular membrane, retinal fold, or hemorrhage. And therefore, if no break is seen, it does not mean that the detachment is purely tractional. A change in morphology may represent a change in mechanism. And this distinction is important because the surgical problem also has now changed. Traction must still be relieved, but the retinal break and the associated rhegmatogenous component must also be managed as well. So the high yield message over here is that when the detachment becomes too extensive, too convex, or too mobile to be explained by the visible traction, actively suspect combined TRD or a rhegmatogenous retinal detachment. Now let us focus on the practical clinical assessment of a TRD. First, we'll discuss the symptoms. An extramacular TRD may cause little or no visual disturbance. As traction approaches or involves the macula, the patient now develops metamorphopsia, reduced central vision, or progressive visual loss. A sudden marked drop in vision may instead be due to the vitreous hemorrhage. Photopsias are less characteristic of a slowly progressive pure TRD. New flashes or a sudden field effect should raise concern for an acute vitreoretinal event or an added rhegmatogenous component or a break. Next is fundus examination. On fundus examination, you basically document the location and extent of the detachment, its relationship to the macula, fibrovascular proliferation and tractional points, retinal folds and vascular distortion, vitreous or any preretinal hemorrhage, active neovascularization and previous PRP marks, and any visible or suspected retinal break. Compare with previous examination or photographs whenever possible to determine whether the detachment is stable or progressing. When the anatomy cannot be defined clearly on examination, imaging becomes the next step. Imaging in TRD should be selected according to the clinical question. The most useful investigation for the posterior pole is OCT or optical coherence tomography. OCT helps determine whether the fovea is attached or detached, how traction is affecting the macula, whether there is retinal distortion or displacement, and whether the anatomy is changing on serial scans. It is also useful for distinguishing tractional retinoschisis from true retinal detachment. In tractional retinoschisis, as we discussed, the separation occurs within the retinal layers, and in true TRD, the full neurosensory retina separates from the RPE, creating a subretinal space. OCT may also show associated diabetic macular edema, outer retinal damage, or chronic retinal distortion, which can all influence the visual potential. However, OCT only shows the area included within the scan. It cannot exclude peripheral traction or an occult retinal break outside the scan field. When the fundus cannot be visualized because of dense vitreous hemorrhage or another media opacity, B-scan ultrasonography becomes important. It can identify significant retinal elevation and may demonstrate vitreoretinal membranes or traction behind the hemorrhage. But a negative B scan does not completely exclude a very small or peripheral tractional retinal detachment. Next is fluorescein angiography, including the ultra wide field imaging when available, is not really required simply to prove that traction exists. Its main role, however, is to assess the underlying proliferative disease, including retinal non-perfusion, active neovascularization, any leakage, and residual untreated ischemic retina. OCT angiography also may demonstrate non-perfusion areas and neovascular complexes, but it remains as an adjunct rather than an essential test in the routine assessment of established TRD. So the practical imaging framework is OCT will define the macular anatomy, B-scan evaluates the posterior segment when the media are opaque, and angiographic imaging assesses the activity and extent of the underlying proliferative disease. Now let's talk about the management of tractional retinal detachment. Management of TRD depends mainly on the relationship of TRD to the macula, its documented progression, whether the detachment is pure or combined, symptoms and visual potential, and the risk associated with surgery. Not every TRD requires immediate surgery. A stable extramacular TRD may be observed in a selective patient, provided that the follow-up is reliable and the anatomy can be compared over time. Observation should include control of the underlying proliferative disease, and documentation with examination, photographs, and OCT must be done. However, extramacular does not automatically mean harmless. If the detachment is progressing towards the macula, the management will change. A progressive macula-threatening TRD generally favors vitrectomy because central vision is at risk even if the visual acuity is right now good. A macula-involving TRD also generally favors surgery when useful visual potential remains. A combined TRD or RRD is a surgical indication because treatment must address both the traction and the retinal breaks. Another feature is the chronicity of the retinal detachment. Chronicity definitely affects the prognosis, but it should not be used as an automatic contraindication to surgery. Even a long-standing macula-involving TRD may obtain anatomical and sometimes functional benefit in a carefully selected eye. Similarly, visual acuity should not be used in isolation. Good vision does not exclude progressive macula-threatening traction, while poor vision does not automatically mean that the surgery will be futile. The decision, therefore, should combine the anatomy, progression, mechanism, visual potential, and the operative risk involved. Then we also have the panretinal photocoagulation. Now, PRP and surgery, they both have different roles. PRP reduces the retinal ischemic drive and helps control the neovascular activity. However, PRP does not mechanically release and establish tractional detachment. Systemic optimization, including control of diabetes, blood pressure, other medical risks, should proceed alongside the retinal management. So, the practical framework is in case of a stable extramacular TRD, the observation may be appropriate. For progressive macula threatening TRD, surgery is generally favored. For macula involving TRD, surgery is generally considered when useful visual potential is present. And for combined RD, surgery is required to address both the mechanisms. Next, let us talk about the anti-VEGF and the crunch phenomena. Anti-VEGF in an eye with TRD must be understood in three different contexts. Anti-VEGF as a treatment for the proliferative diabetic retinopathy, anti-VEGF as a preoperative adjunct before vitrectomy, and rapid worsening of the traction after anti-VEGF, that is the crunch phenomena. In PDR, the anti-VEGF causes regression of the neovascularization. However, it suppresses the vascular component of the disease. It does not mechanically remove that fibrous component or that established fibrovascular traction. Before diabetic vitrectomy, anti-VEGF may reduce the vascularity of the fibrovascular membranes, and this can improve the visualization, reduce intraoperative bleeding, and may reduce iatrogenic retinal breaks and postoperative vitreous hemorrhage. But anti-VEGF requires greater caution when substantial pre-existing fibrosis and traction are already present. Here, the term anti-VEGF crunch describes a rapid development or progression of TRD after an anti-VEGF injection in an eye with proliferative retinopathy. And the proposed mechanism over here is that giving anti-VEGF causes rapid regression of the neovascular tissue followed by contraction of the pre-existing fibrovascular complex and thereby increasing the traction on the retina. Now, although the anti-VEGF crunch is well recognized, its exact frequency is not well defined. However, concern is greatest in eyes which have severe active PDR, extensive fibrovascular proliferation, marked pre-existing traction, or those with broad complex fibrotic membranes. Reported worsening may occur over days to weeks after injection. At the same time, randomized trial data have not shown an overall increase in TRD among ordinary trial eligible eyes with PDR treated with anti-VEGF. But these results should not be applied indiscriminately to advanced fibrotic macula threatening eyes already being considered for surgery because such high risk eyes were not well represented in those trials. Therefore, neither extreme is correct. Anti-VEGF does not generally cause TRD in routine PDR cases, but rapid tractional worsening can occur in selected eyes with severe pre-existing fibrovascular disease. Therefore, when anti-VEGF is used as an preoperative adjunct in a high-risk tractional eye, surgery should already be planned and unnecessary delay after injection should be avoided. Any new visual loss or rapid progression of traction after injection requires urgent retinal reassessment and may require a vitrectomy. The purpose of vitrectomy in TRD is to relieve the pathological traction pulling on the retina. The main surgical principles over here are: number 1, removing the vitreous traction; Number 2, segment the interconnected with fibrovascular membranes. Number 3, delaminate persistent tractional tissue wherever necessary. Number 4, identify and manage the retinal breaks. Let us understand each step one by one. Relieving the anterior-posterior traction. In many eyes with TRD, the posterior vitreous has separated in some areas, but it remains firmly attached at the sites of fibrovascular proliferation. These remaining attachments act like tight bands between the vitreous and the retina. Movement or contraction of the vitreous can therefore pull the attached retina forward. The surgeon therefore removes the free vitreous and releases these anteriorly directed forces as safely as possible. However, the posterior hyaloid should not be forcibly pulled away from the areas where it is tightly adherent to the fibrovascular tissue. The underlying diabetic retina may be thin, may be ischemic and fragile, and forceful separation can lift the retina further and create an iatrogenic retinal break. Instead, the attached posterior hyaloid may be cut or truncated around the fibrovascular attachment so that the vitreous no longer transmits the traction to that area. So the goal is not to create a complete posterior vitreous detachment at any cost. The goal is to stop the vitreous from pulling on the retina. Next is segmentation. Fibrovascular membranes may also connect several areas of the retina. When one part of this connected membrane contracts, the force can be transmitted across the entire membrane complex, and this is known as tangential traction. This can be relieved by segmentation and delamination. Segmentation means cutting the membrane bridges between these areas and dividing the fibrovascular tissue into smaller islands. This interrupts the transmission of tangential traction across the retinal surface. The membrane may still remain attached at individual points, but the different areas are no longer pulling against one another through one continuous sheet. After segmentation, what we have is delamination. So what happens after segmentation is that some fibrovascular tissue may still remain tightly attached to the retina and continue to elevate or distort it. Delamination means carefully separating this persistent tractional tissue from the retinal surface. Depending on the anatomy, the surgeon may use the vitreous cutter, forceps, scissors, or bimanual dissection. The instrument is less important than the principle. Remove enough tissue to release clinically significant traction without causing unnecessary injury to the retina. It is not necessary to remove every visible fibrovascular segment. A small island of tissue that is no longer pulling on the retina may sometimes be left in place, particularly when it is tightly adherent to a major retinal vessel, and removal would create a greater risk of bleeding or retinal break formation. So, to summarize, these three terms describe different ways of relieving traction. We have truncation, which relieves the anterior posterior traction, and it means cutting the attached posterior hyaloid around a fibrovascular adhesion so that the vitreous no longer pulls on that area. Segmentation means dividing the connected fibrovascular membranes into smaller islands to stop traction from being transmitted across the retina, that is, relieving the tangential traction. Delamination means separating the membrane from the retinal surface when it continues to pull on or distort the retina. Right? So, in simple terms, truncation relieves the vitreous pull, segmentation breaks the membrane network, delamination removes the persistent traction from the retinal surface despite segmentation. Step number 4 is identifying and managing the retinal breaks. Retinal breaks may already be present before surgery as in combined TRD. They may also be created during membrane dissection. The surgeon must therefore inspect the retina carefully after traction has been released. If a break is present, any traction around it must be removed and the rhegmatogenous component must be treated appropriately. This may require subretinal fluid drainage, retinopexy, and internal tamponade, the principles of which we discussed in the video on management of RD. In a pure TRD without a retinal break, the retina may remain elevated immediately after the traction has been released because the subretinal fluid can take some time to absorb. Therefore, direct drainage of subretinal fluid is not always necessary. Similarly, gas or silicone oil tamponade is not automatically required simply because a TRD was present. Drainage, retinopathy, and tamponade become more relevant when there is a pre-existing or iatrogenic retinal break, a retinotomy or retinectomy, when there is residual traction or inadequate retinal apposition. So the main surgical idea is the surgeon is not primarily pushing the retina back into place. The surgeon is just carefully removing the forces that are pulling it away from the RPE. Alright, this completes the TRD surgery. After TRD surgery, 3 outcomes should be discussed separately: anatomical success, visual recovery, and long-term disease control. Modern vitrectomy often achieves retinal reattachment, but anatomical success does not guarantee good vision. The strongest predictor of post-operative vision is the pre-operative visual acuity. Also, visual recovery may still be limited by macular ischemia, chronic outer retinal damage, long-standing macular detachment, diabetic macular edema, neovascular glaucoma, or complex retinal disease. Chronicity also can worsen the prognosis, but it is not an automatic contraindication to surgery. Combined TRD and RRD is more complex, but again, it's not a hopeless case. Patients should therefore be counseled separately about the chance of retinal reattachment, separately about the realistic potential for visual improvement, and the need for continued control of the underlying proliferative disease. All these 3 things are important.